Sometimes the face reveals the secret the brain is trying to hide. And today, we see one of the cases in which the brain is hiding something, but the face reveals the secret. What's up, ladies and gentlemen? Welcome back to Neuro Sketch with Dr. Kenny. But if this is the first time you're seeing this channel, don't forget to subscribe. Let's talk about the Horner's syndrome, and I want to know if you are curious, and if you are, then tell me the similarities between these two pictures, because these two people, they possibly have the same pathology. And let me make it easy for you. Yeah, I want you to tell me the similarities between this eye and this eye, and to narrow it down, tell me about the upper lid of this one and this, and of course the pupil. Yeah, what are the similarities between these people? You can pause for a second, try to think about it, and I imagine you have already thought about it, and you can agree with me that these two people, they have droop of the upper, like the upper is a little bit dropping down, and this is called drooping of the upper lid, which we already discussed in the previous we already talked about in the previous discussion, and we said it is called ptosis. And yeah, we said this is incomplete ptosis because the upper lid has a little bit managed to open the eye, at least to this extent. And then take a look at the pupils of the left side. Yeah, compare them with the contralateral pupils. You will see that these pupils constricted with comparison to the contralateral pupils. We have two things. You have the drooping of the upper lid and the pupillary constriction. Pupillary constriction is also called meiosis. Remember, we have a separate discussion that we have talked about the pupillary light reaction, and also we've just discussed the ptosis, which is coming as a part of extraocular muscles, of course, and levator palpebral superioris, which is the first part, just the previous part that we have discussed. But guys, is this complete ptosis or incomplete? This is the incomplete ptosis, which is also known as the partial ptosis. But let's remind ourselves what we've just discussed in the previous discussion. Yeah, so we said you have two muscles, levator palpebral superioris and Mueller's muscle, and the levator palpebral superioris is the one which is playing a major role in elevation of the upper lid. Remember, the levator palpebral superioris is the one which is initiating elevation and also doing the bigger part of elevation. That is to say, without levator palpebral superioris, we can never open the eye, like your eye can never be open because the upper lid will drop, which is called drooping. Okay, and the Mueller's muscle, the function of the Mueller's muscle was just to maintain the state of elevation. Like if it is like this, and then the Mueller's muscle will add 1 to 2 millimeter elevation to keep that state of elevation. Okay, and remember, the Mueller's muscle, it is a smooth muscle, whereas the levator palpebral superioris is a skeletal muscle. The Mueller's muscle, being a smooth muscle, means it's innervated by autonomic nervous system, and we said it is sympathetic innervated. Now you can see this person as these two people have managed to open their eyes at least to this extent. That is to say, the levator palpebral superioris in these eyes are completely fine, because otherwise these eyes would be completely closed. Yeah, so the problem here, it is not levator palpebral superioris, it is probably Mueller's muscle or the nerve which is supplying the Mueller's muscle, which is the sympathetic innervation. So the problem here is sympathetic nervous system. Now let's go back to the pupillary constriction. Like we've seen, we have pupillary constriction on these sides of the eye, and we want to figure out what are the possibilities of having pupillary constriction on one eye and leaving the other one. Remember, we said the control of the size of the pupil is under autonomic control, and autonomic means you have a sympathetic nervous system and a parasympathetic nervous system. What is the sympathetic effect to the pupillary size is to dilate the pupil. And why do you have to dilate your pupil? Remember, the sympathetic nervous system is fight or flight mode, and in fight or flight, you need your pupil to dilate so as to get enough amount of light to go to a retina so as to take an appropriate action, whether to fight with that dangerous stuff or to run, like to to flight, something like that. But the parasympathetic nervous system is a rest and digest system. And the parasympathetic nervous system is the rest and the digest system. And why would you dilate your eye in the parasympathetic nervous system? Because that is a rest and a digest. You want to rest, and to rest is to sleep. So you're closing your pupil. Yep. Okay. So that was a quick reminder on the sympathetic effect to the eye is pupillary dilatation, and parasympathetic effect is pupillary constriction. And the size of the pupil, it is a result of balance between sympathetic nervous system and the parasympathetic nervous system. And what are the possibilities of having pupillary constriction? Pupillary constriction can be due to parasympathetic innervation, like exaggeration of the parasympathetic nervous system, or blocking of the sympathetic innervation. Yes, so that is a quick reminder on the effect of the sympathetic and the parasympathetic innervation to the eye. The sympathetic will result into pupillary dilatation, and the parasympathetic will result into pupillary constriction. And it is the balance between the sympathetic and the parasympathetic innervation to the eye that control the size of the pupil. The pupil is the way it is because of the balance between sympathetic and parasympathetic nervous system. The sympathetic is resulting into pupillary dilatation, which is called mydriasis, and parasympathetic is resulting into pupillary constriction, which is called meiosis. And we see in our case here, we have unilateral pupillary constriction, constriction of this pupil, while the other one is normal or dilated. What are the possibilities? Like, what are the causes of unilateral pupillary constriction? And as far as autonomic nervous system is concerned, you have two possibilities of having unilateral pupillary constriction. Number one is either you have an exaggerated parasympathetic effect to this side, because the parasympathetic is the one which is resulting to pupillary constriction. Now, if you have exaggerated parasympathetic innervation to one eye, you will have constriction of one eye compared to the other one. And the possibility number two, it is denervation, like cutting off the sympathetic nervous system, because it is the balance between parasympathetic and the sympathetic that brings about the normal size of the pupil. Now, if you cut the sympathetic innervation, that means the parasympathetic will take over, and so you have pupillary constriction. So these are the two possibilities here. Either you have a cut off of sympathetic nervous system, or you have exaggerated parasympathetic innervation. So these are the possible mechanisms that can result into unilateral pupillary constriction. But we have two things in hand. Remember, we have pupillary constriction on this eye, also incomplete droop. The pupillary constriction could be due to elevated or exaggerated parasympathetic or inhibited sympathetic. But the incomplete droop we've narrowed down into either the myogenic, which is Mueller's muscle, or the sympathetic denervation. But because I have two things in common here, I have sympathetic in the Mueller's muscle and also sympathetic denervation in the pupillary constriction, then this is pointing into the sympathetic origin. Like, all these problems that are brought here, they are due to the denervation of the sympathetic supply. And you guys remember, the sympathetic nervous system is thoracolumbar. It's either coming from the thoracic part of the spinal cord or the lumbar. And the one which is coming to the head to supply the structure of the head, they are coming by the way of the superior cervical ganglion through blood vessels, which could be the internal carotid artery or the external carotid artery. You see, you have the superior cervical ganglion here, and from here, the sympathetic fibers are carried by the way of arteries, and these sympathetic fibers are called the carotid plexus, and from here they are going to supply different structures within the head, and to our case, they are also going to supply the pupillary muscles. These carotid plexus, they are going to different structures of the head, including the pupil, where they are going to result into pupillary dilatation. And whenever you see a lion freaking out, you have pupillary dilatation for you to be able to fight or to run away from that dangerous dangerous animal. I guess I've spent enough time to be able to describe the Horner syndrome. So what really is an Horner syndrome? Well, Horner syndrome is a rare condition which is caused by damage to the sympathetic nerves of the face, and that will result into pupillary constriction, which is called meiosis. You have ptosis, which is incomplete drooping of the upper lid. I'm repeating one more time, it is incomplete drooping, because if it's complete, then the problem is the oculomotor nerve or the levator palpebral superioris rather than the sympathetic supply. But what is sympathetic effect to the sweat glands? Yeah, it supply, the sympathetic nervous system is supplying the sweat glands, and whenever you have damage to the sympathetic, whenever you cut off the sympathetic supply to a specific part of the body, you will have inability of producing sweat. So you have anhidrosis, which is one among the characteristic feature of the Horner syndrome. So you have anhidrosis, which is the absence of sweating on the ipsilateral side of the face. The same side of the face that has got, meiosis and the droop is where you have lack of sweating or absence of sweating. But remind me, what is the sympathetic effect to the blood vessels? The sympathetic nervous system results into vasoconstriction. And what happens if you do not have the sympathetic innervation? Yeah, you will have exaggerated vasodilatation because the parasympathetic is taking over, and so you have vasodilatation. What happens in terms of resistance of the blood vessels? What happens when you have vasodilatation? Resistance goes higher or lower? Goes lower. Yeah, and because the resistance goes lower in vasodilatation, more and more blood is flowing to this region of the face, and because you have too much blood around there, you'll have redness around, which is another characteristic feature of the Horner's syndrome. Yeah, so you have redness and increased temperature of the skin. Why increased temperature of the skin? Because the blood is flowing there, and you have elevated temperature. Yes, this is a clinical picture of the Horner syndrome. But what is a classic representation of Horner syndrome? That whenever you see it, you definitely go for Horner's and only Horner's syndrome. Yeah, we have a triad here, which is called the triad of Horner syndrome. This is a combination of meiosis, ptosis, and anhidrosis. Yeah, these three features, whenever you find, they are ipsilateral, the same side of the face. And whenever you find your patient has these features, you definitely go for Horner's syndrome. Okay, a clinical scenario here for you. A 30-year-old man presents with the drooping of the right eyelid and a constricted pupil on the same side. Which of the following additional signs would most likely point to a diagnosis of Horner's syndrome? And now I want you to give me answers. Write your answers and see you in the next discussion. Bye bye.